Hello, everyone. Welcome. Welcome. My name is Brian Scarpelli. I'm the Executive Director of the Connected Health Initiative. The Connected Health Initiative, very briefly, is a multi-stakeholder, consensus-driven policy advocate coalition focused on advancing incremental and sweeping and everything in between responsible policy changes that will enable the use of digital health tools in improving patient outcomes, reducing costs, augmenting population health management, and supporting the healthcare workforce. So this is a really great event here that we're holding today, and I thank you again for being here. Health equity through wearables, reducing costs, saving lives. And I'll turn it over to Taylor in just a moment. But as a little bit of framing up, I think you're here because you would agree that digital healthcare solutions are really important for providing health services for unserved and underserved Americans, and wearables play a particularly important role in both preventing and treating disease. So while that's true, and I hope you agree with that, like we do, there's still a lot of barriers that stand in the way for consumers to be able to use some of even baseline wearable tech that's available in many other use cases to improve their own health and manage their own health and be proactive in this context. So there are some legislative solutions, for example, that the Connected Health Initiative has been looking at that we will talk about, and I will leave it to Taylor to elaborate on, but the Wearable Equipment Adoption and Reinvestment in Technology, or Wear It Act, which has the potential to reduce some of these barriers. And more broadly, I think, this is a great conversation and a very timely conversation to explore how policymakers can help on make available wearable health technologies and associated software to improve health equity. So we'll talk about some of the current future uses of the wearable devices, some of these barriers I alluded to, and what steps policymakers, namely Congress, can take. Thanks again for being here. I should turn it over to you, Taylor.
Thanks so much, Brian, and thanks everyone for joining us. As Brian mentioned, my name is Taylor Downs. I am the Federal Policy Manager for the Connected Health Initiative. That means that I do a lot of our federal-facing policy advocacy work, especially on digital healthcare, digital health technology, wearable health devices, and a lot of the other pieces that we work on. But those are the ones that are relevant today. So again, thank you all for joining us. We're really excited to have this conversation. I have an excellent panel here joining me today. I'm going to let them introduce themselves. I'll just start going around my screen, and I will start with Robert Longyear.
Hi, everyone. I'm Robert Longyear. I'm a co-founder here at Avenue Health. We are a remote patient monitoring and chronic care management company. So we work with academic medical centers, federally qualified health centers, rural health centers, and independent practices to fully launch and manage remote patient monitoring, remote physiological monitoring programs, as well as chronic disease management programs, primarily for hypertension, diabetes, COPD, congestive heart failure, and stroke.
Excellent. Thank you so much. I will move to Dr. Lauren Chung.
Thanks, Taylor, and thanks all for being here today. I'm really excited to be joining you all. As an introduction, I am a physician on the health team at Apple. I'm also still a practicing faculty member at Stanford, where I was active in implementing telemedicine and starting a virtual primary care clinic that was geared towards caring for healthy and rising risk patients, using information that was captured both in the clinical setting and outside of it. Now, many people are familiar with Apple, but maybe less familiar with what we do in health. And so at Apple, our goal really is to empower users with their health information and to make it easier to understand what to do for your health so that you're no longer a passenger on your journey, but firmly in the driver's seat. And so we do that by focusing on scientific validation, actionability, and privacy within all of our health and wellness features. And I'm excited to share a little bit more about these features later today, including the things that we're doing for our users with the features that we have in 18 different areas of health and wellness, and also how we're enabling the medical and scientific community.
Thank you very much, Dr. Chung. I will move to Sarah Pincus.
Hello, my name is Sarah Pincus. I'm the Manager of Health Policy at Breakthrough T1D, formerly known as JDRF. And Breakthrough T1D is the largest nonprofit funder for type 1 diabetes research. And wearable health devices are really important to the type 1 diabetes community. And as an organization, we are always advocating for better access to those devices. So thank you for having me. Really looking forward to the discussion today.
We're excited to have you too, Sarah. Thank you. And last but not least, I will move on to Claudia Teguez. Oh, Claudia, looks like you're still muted.
Thank you,
There.
Taylor, and thank you for inviting me to speak here with all these beautiful people. I'm super excited. So I'm the executive director at the Medical Society of Northern Virginia. It was founded in 1884, and we represent about 1,800 independent physicians who live or practice in Arlington, Fairfax, Loudoun, or Prince William County. Our membership is comprised of about 35% primary care physicians who are actually very actively using RPM devices for their patients.
Excellent. Well, thanks so much to everyone. We've got a pretty wide range of expertise here, as well as folks who are working in a number of different use cases for RPM. So I'm really excited to see your sort of unique perspectives. But first, let's sort of start with a bit of a level setting here, groundwork. So I'll open this question up to anyone who'd like to speak. So could you tell me about sort of your experience with using remote patient monitoring tools? How has it changed the way that you've seen medicine be practiced, or the way that you personally might interact with the healthcare system?
I'll go first. So I will say that the introduction of RPM and value-based contracting for physicians has been an impetus for adopting those solutions to help manage chronic conditions. So value-based care, I don't know if all of you are familiar with that, but basically physicians get to keep a share of the contract agreement at the end of the year. And so that has been a really good incentive, I think, for physicians to adopt the technology, but also a good way to help their patients improve their chronic health diseases.
Thank you. Anybody else? Robert, see you came off mute there.
Yeah, I'll jump in. So we built our entire business and company around remote physiological monitoring after it started to be reimbursed by the Medicare physician fee schedule in 2018, 2019. And what was I think most exciting to me and why I got into this space was like looking at how we can make primary care in particular and outpatient care more proactive when it comes to managing patient outcomes. And I always like to say, and Dr. Chung alluded to this earlier, that providing patients with wearables and medical devices in the home so that they can track their own metrics is just as important as transmitting that data to the provider themselves or the care team. So RPM is sort of a multi-function intervention or care model where patients can really understand what's going on, and through that understanding, manage their own health in the home better. And when there's certain trends or issues that come up, you have sort of that trained eye looking at that data coming in to manage that patient's care more effectively, and ultimately reach back out to that patient if something needs to be changed as a part of their treatment plan. So that may be medication adjustments sooner than the typical every 6 months or every 3 months. It may be behavioral-based interventions, helping patients live a healthier lifestyle, improve their diet, and it may be a sort of referrals to specialists sooner than you might get through that standard in-office visit every 3-month cadence. So it's been absolutely transformative for our customers and our patients that we care for every day.
I just want to echo something like what Robert just said, that in the type 1 diabetes community, and I'll refer to type 1 diabetes as T1D, that in that community, remote patient monitoring has allowed people to be at home and not rely as much on doctors and doctor visits, since continuous glucose monitors known as CGMs and pumps, as well as automated insulin delivery systems can help manage your glucose levels through the sensors in the devices on your body, that this allows for more power of day-to-day management of T1D and gives someone the availability to share that data with their doctor. And then what Robert said, that doctor can then use that and go back to the patient for managed care plans.
I think what all of us are really alluding to here is that we're finally starting to see that patient monitoring and remote patient monitoring is starting to live up to its promise of increasing access and improving outcomes. And so I'll maybe go through a couple of examples that we've seen of how our devices are being used to really kind of help with those improved outcomes as well as access. And so I'll start with what we saw during the pandemic, which is that we saw how doctors all over the country really turned to FaceTime to stay connected to their patients. They were also using FaceTime to help their patients who are isolated in the hospital really stay connected to their loved ones. And we were really interested in seeing that they were also starting to use our medically regulated features like the ECG app to care for their patients at home. And so in those instances, the providers were actually asking their patients to send them EKGs that were taken from the Apple Watch so they could then help them understand what to do without actually having to see them in person in the clinic. And just to kind of give one more example of how we're seeing this come to life, I want to share some of what Ochsner is doing. So Ochsner is a health system in Louisiana, for those who aren't familiar with it. And they have a number of what they call digital connected care programs, which have been really, really interesting and kind of speak to a little bit of what Robert was talking about. So for those who aren't familiar with what we at Apple do, not only does Apple create our own features, we have features that support the larger health ecosystem. So one of those features is HealthKit, which is a set of APIs that with your permission allows third-party devices the ability to write information into the health app so that it can be stored in one central and secure place. Well, Ochsner had this population of patients with really poorly controlled hypertension. They decided to give these folks a connected or a Bluetooth connected blood pressure cuff and ask them to take their blood pressures at home. The Bluetooth connected device wrote the information into the health app, and using these HealthKit APIs, Ochsner was actually able to directly pull that information into their EHR, where it was being monitored by a pharmacist. Now, that pharmacist then reached out to any patients whose numbers weren't well controlled, and they adjusted their plans as needed. And so with that program, more than 79% of patients were able to get their blood pressure under control within 6 months. But I think even more surprising was that this resulted in a 29% decrease in these patients' clinic visits to the primary care office. So it really did open up access to other patients who needed care. And that's just one of the examples that we're seeing. It's been so successful that Ochsner has done a similar program to care for their patients with diabetes, as well as a new Connected Moms program as well.
That's wonderful. That's really, really encouraging the way that the remote monitoring tools have been able to make such huge changes for people. Robert, I know that's something that you have experienced with your groups that you work with as well. Do you want to talk a little bit about how that might affect folks in rural areas, or what you've seen in your practice?
Absolutely. So the story that Dr. Tung just provided is very similar to what we do in other states. So we set these programs up on behalf of brick and mortar clinics like Ochsner, and we bring in registered nurses, pharmacists, and other clinicians to ultimately review that data from patients that's coming in. We actually benefit from the Apple Health Kit as well. When patients give us permission, we're able to pull in data that is sort of synced into that sort of data set. And so our nurses are able to sit there in our platform and ultimately review data from patients, including activity data, blood pressure data, blood glucose data, weight data. And so we're really able to sit there and understand what's going on with patients and then collaboratively work with them. One, if we see something that's not going well, or just on an ongoing basis, checking in with patients and making sure that they're reaching their health goals proactively through a shared care planning session with one of our clinicians. We operate these programs on behalf of their typically primary care physician at a standard medical clinic. So the example I think you're referring to, Taylor, is some of our work with a very large federally qualified health center or rural health center in Alabama, where we had a very uncontrolled hypertension population, and we were able to roll out our program to a couple thousand patients during COVID through a grant that was funded by the federal government. And we have been able to demonstrate statistically significant reductions in blood pressure for those patients. And what's really interesting about RPM is that patients are often willing to get on the phone with one of our nurses, or who we refer to as their health coach, for 20 minutes or 30 minutes twice a month, when they may otherwise not have transportation or be able to get into the clinic physically. And so by bringing this care into the home and by bringing wearables and data into what we're doing, we're able to increase the access to qualified healthcare providers and services where patients otherwise may forego going to the clinic. And so that sort of remote connectivity is really important, just sort of through a general health access perspective, but also it helps patients engage more with their health. So we're not just replacing sort of your standard office visit and making it more convenient. We're also having patients sort of increase the amount of engagement that they're doing in a really cost-effective way. So we've seen tremendously good outcomes, great feedback from patients, and our model is very much based on the relationship between the health coach and the patient. So they are assigned, they stay together, and they're able to sort of work on those health goals proactively over the course of several years in some circumstances.
Wonderful. And so we've talked a little bit about a couple of the different chronic conditions that can be good candidates for treatment through wearable health and remote patient monitoring. Claudia, I know you're the doctors that are part of the Medical Society of Northern Virginia treat a wide variety of patients with a number of different types of conditions. How have you seen doctors implement remote monitoring for care for patients with these other different types of conditions?
I think that patients were very receptive. I mean, at the beginning, it was always anything new is always very hard. But I think now we are seeing recurring stories and about really good outcomes for the patients, and also very focused on like the shared savings aspect of their models. But I would like to address one thing on all of this is that closing the gap in equity, like in rural areas or inner cities, is something I think that really needs to be discussed when we talk about RPMs and multiple use devices. Northern Virginia is a very affluent area, so I cannot say that my doctors really truly represent what these other pockets of vulnerable populations where they reside all over the country. For the most part, as you know, in this area, people are well educated, they're making well above the national average. And so it behooves them and it's to their interest to adopt new technologies right away. And there's no barrier on cost. I think that what we've seen is a lot of the vulnerable populations, like the minimum wage workers, sort of do struggle with maintaining the chronic conditions because they have to work 10, 12 hours a day. They cannot get to their physicians. It's cost prohibitive for them to buy a device that, to share that data with their physicians or with their PCPs. And so I think that, the legislation that you guys are working on, it's very much spot on to be able to open up that, close the gap on the barrier, but to open up an opportunity for these populations to get access to care in a more equitable way.
Yeah, and I definitely want to talk about the WEARED Act more, but I sort of, before we get there, want to go in a little bit on, you've talked some about the challenges that we face in seeing broader adoption of RPM, and I want to open that up to the panel. Sarah, I see you nodding about challenges that might inhibit broader adoption. So I'll start with you, and then folks can jump in as they see.
Sure. So for the type 1 diabetes community, there are certainly some challenges. One being physician awareness and understanding. Are doctors aware of what is on the market? Do they understand the benefits of devices? Are doctors even going to prescribe a device? Also, there's technology literacy. Not all patients are going to be tech savvy or comfortable using digital health tools. And also adequate reimbursement. Many health insurance companies are still offering very limited reimbursement when it comes to wearable health devices. And also a lot of insurance plans have a preferred device that they will cover. And if that is not the device that you want to use, people are going to face higher out-of-pocket costs for a device. And touching a little bit on what Claudia just mentioned, like health disparities, not all patients have equal access to technology. Those more rural communities may not have the means to get to a doctor, or there may not be a doctor within 20 or so miles to them. And what we know in the type 1 community is that Black and brown kids in general are less likely to receive a continuous glucose monitor compared to their white counterpart. So a lot of challenges remain in the type 1 diabetes community in terms of adoption of devices and remote patient monitoring.
Thanks, Sarah. That really puts a pretty fine point on it. Claudia, I see you came off mute. Do you have?
Yeah, I just wanted to say, Sarah is so right. I think that the gap in access and equitable access to healthcare for all, it's really at the heart of this. We in affluent areas like Northern Virginia, we sort of tend to not think about that population so much, but the fact of the matter is that even here there is a need, again, with those minimum wage workers, or the workers that help in the house or help taking care of children on a day-to-day basis. I will say that cost is one thing and the clinical care is another, but the wraparound services around social determinants of health are also very important. Food insecurity, housing, access to good education, nutrition, all of those things that encompass social drivers of health.
Robert, I see you came off mute. Do you have other things you might want to talk about with the challenges for remote monitoring?
Yeah, I would say, reimbursement is a challenge. And I'm going to say a couple points on this. So, like our ability to work with the federally qualified health center and rural health centers that we have worked with really stemmed from a program from the Health Resources and Services Administration during COVID. And it was really viewed as sort of a COVID response approach. We view RPM as a chronic care intervention, right? So we have a chronic disease epidemic in the United States. This isn't new information for many folks. So, we have pretty high rates of type 2 diabetes, and we have high rates of hypertension, cardiovascular disease. And so my hope from the policy community is that we sort of look at RPM as an effective access to care and chronic disease sort of care model intervention, and not just, hey, we just need to make sure people can contact their doctor when it's not safe to go in due to infectious disease. So my hope is that narrative changes around to like, this is something that transforms our care delivery system into being more effective and more proactive. Where this is a place where the United States falls really short compared to our economic peers around the world. And so that's my first point. Insurance coverage is really important in that. So the HRSA funded program allowed us to do this program for patients without any cost for patients, which was really, really nice. Medicare, I believe last year in the fee schedule, started allowing federally qualified health centers and rural health centers to actually receive reimbursement for remote patient monitoring, remote physiological monitoring, just like standard Medicare patients. So that was a step in the right direction, but we have to look at the sort of making sure reimbursement rates are right-sized so that programs are sustainable. And we have to look at patient cost sharing. So from Medicare, reimbursement's great. Patient cost sharing is still the standard sort of 20% roughly. And so that number is prohibitive to a lot of our patients. It's the number one reason a patient may not participate in our program after their physician says, and you should do this. So it's the number one reason that we see declines. It's only, roughly $25, $30 a month on average, but that's a lot of money to some people. And it's really important to note that cost sharing can be a barrier, and oftentimes those are patients who would most benefit from these services. So to use a scientific term, we have a bit of a selection bias effect here where we're not necessarily getting this important intervention to the folks that would benefit most from it. And that's a lot of times due to cost. So improved coverage in Medicaids across states is something that we think would be really helpful to sort of advance the equity conversation here. Improved government programs for federally qualified health centers, and then improved access through commercial insurance coverage policies as well is something that we advocate for because we're a very insurance-based model. There's obviously models where physicians are not necessarily receiving reimbursement, but they are recommending these wearables and technologies to their patients, and so that's something where I think the WARED Act may be very helpful in both circumstances, because the reimbursement from Medicare and for most insurances for RPM generally covers one device. At least that's what's most, I should say that's the only cost-effective way to run the program. Whereas patients don't just have one condition. So our patients with hypertension often have type 2 diabetes. Our patients with COPD often have hypertension. And so in a lot of circumstances, we want multiple sort of data streams coming in so we can monitor multiple conditions. I know I said a lot, and I was kind of a sidebar, so apologies for taking up too much time.
That's okay. Dr. Chung, you want to jump in?
Yeah, I think it is clear based on all of these comments that reimbursement remains one of the largest challenges for the adoption of wearable technologies in general. And we do need to find ways to improve the reimbursement structures that incentivize the use of this data and review of data outside of the clinical setting. But as a practicing doctor, I do think there is one other thing that I'll call out that I think still remains a challenge, which is even if physicians are aware of these devices and their ability to kind of help with improved outcomes, they often don't know how to incorporate the use of this data into their workflows in a way that is efficient, that allows them to practice the way that they are used to practicing, especially when they are seeing both patients in person still and trying to monitor their patients outside of the clinical setting. So I just want to kind of reinforce that in addition to reimbursement, there are some other challenges. And I do think that those types of workflows are just a really, really important thing to improve adoption.
Absolutely.
I want to be cheeky here and ask Dr. Chung to be our champion to actually get a some revenue, some kind of line of funding to teach physicians how to incorporate data into the workflow.
I mean, that's a great creative solution for sure. So, we've been discussing remote monitoring here quite a bit and some of the challenges, some of the different solutions that might exist, but the real goal of most of these wearable health interventions is to augment the delivery of preventive care and to sort of help with that for patients. Dr. Chung, how has your work focused on the preventive care aspect of these wearable devices?
Yeah, it's such a great question. And I do think you're calling out something that is so different about remote patient monitoring. And Robert mentioned this as well, which is the opportunity to proactively intervene before something is actually serious is something that's really important. So we think about prevention and wellness, and we believe that it is really core to the work that we do. So I'll back up and tell a story about how we got into health in the first place. So when we first launched the Apple Watch with an optical heart rate sensor placed on it to more accurately capture active calories, we were stunned by the amount of letters that we received from our users telling us how the watch helped them better understand their health. They were seeing trends with their heart rate and bringing them to their doctors and getting diagnosed with conditions like GI bleed or atrial fibrillation or sepsis even before they actually really had a serious issue. And so they were able to get early treatment. That's inspired us to continue to build health features that help folks both better understand their health before they get a problem, but also help them understand how to take action on that information. So we have features like the activity rings and mindfulness features and sleep features that help really promote healthy lifestyles. But we also have features that are geared towards safety and the early detection of serious conditions like atrial fibrillation, which is the leading cause of stroke. So the Apple Watch can detect that with our medically regulated features like the irregular rhythm notification and the ECG app, so that folks can get treatment before they end up in the hospital with a stroke. We also have a walking steadiness feature, which helps people understand if they're at risk for falls so that they can intervene before they actually have a fall. And we've also introduced new features this year, like our sleep apnea detection feature and our hearing features. But I'll say that we're also excited about how others are using these features to do similar things. And so I'll give you another example of how we are enabling folks to more proactively care for patients outside of a clinical setting. So take, for example, the Corey app coming out of Johns Hopkins. So that is an app that is a comprehensive self-management tool that is paired with the Apple Watch and given to folks who enter the hospital with a heart attack. The goal is to actually reduce 30-day readmissions to the hospital after a heart attack, something that 1 in 5 Americans experiences. Now, by providing patients with the watch and the metrics it monitors when patients leave the hospital, Johns Hopkins was actually able to reduce 30-day readmissions from 20% to 6%, which they estimated also led to a cost savings of $10,000 per patient. So I think what we're seeing is really that there is a lot of ability to actually prevent kind of serious outcomes and serious consequences while also reducing costs in the healthcare system.
Yeah, I think that, the reduction of costs in the healthcare system is a goal that many people who are involved in healthcare share, because, we've seen ballooning healthcare costs over the past, I don't know, several decades at this point, probably. So Robert, you've talked to me a lot before about decreasing costs both for patients and for the healthcare system overall. How have you found that working with remote monitoring tools helps to decrease those costs for both patients and for the general health system?
Yeah, this is my favorite topic, so thank you for asking me. So if you look at why we're doing this in the first place, right? And I'm gonna kind of put my public health hat on here for a minute instead of my health services hat. We really want to prevent the use of the health system as much as possible. That's the highest savings mechanism to sort of solve some of our cost issues in the US. It's the an ounce of prevention is worth a pound of cure that everybody says all the time. The best way to prevent sort of primary prevention is preventing the formation of any condition in the first place. And that's something I think our folks at Apple have done a really nice job with, is sort of putting those exercise and activity features on the Apple Watch, where we can actually encourage folks who don't yet have a condition, who may have a condition like prediabetes, who can actually get out and exercise and lose weight, improve diet, and do some of these sort of healthy behaviors, if you will. So that's sort of step one. We want to do that as much as possible through health education and positive health behaviors. After a condition's been formed and patients are sort of in a chronic care model in primary care, that's really where we think RPM comes in. I'm a proponent of RPM coming in even before that, right, to help the physicians actually prescribe physical activity, prescribe those healthy behaviors before a patient actually ends up with a diagnosed condition in the first place. So I think RPM actually has further upstream functions as well. But right now, it's really focused on those patients who have already been diagnosed. And so really in that case, you've got patients who are relatively low risk, and we're working on actually getting them to a healthy blood pressure or better glucose control. You've also got patients who are at higher risk, right? They have less controlled conditions. They've got really high systolic blood pressures. They have really poorly controlled blood glucose in some circumstances. And so in that case, RPM is a little bit more of a safety net. And that safety net function, I think, is really important, Because if we see patients who are trending out of control, or they're trending in a way that's kind of dangerous, or that may lead to eventually a hospitalization or an emergency department visit, that's really where RPM can help save a lot of money. There's money savings on the long run from preventing the conditions from occurring. It's kind of hard to measure in a lot of circumstances, though. But what we can measure, and there are plenty of studies that have demonstrated so far, is that RPM actually can reduce acute care utilization. So those hospitalizations, those emergency department visits. And when you're doing it properly, when you're running an RPM program using devices, you have skilled people, clinicians, nurses, health coaches, dietitians, pharmacists, and physicians really watching what's going on there with their cohort of patients, you're able to really intervene quickly. So patients who may have a really high kind of out of range blood pressure, you can give them a call within 5 minutes when you get that alert. You can say, hey, how's it going? Let's talk about your health. I saw this reading. Let's take your blood pressure again and see if it's still high. Okay, let me get you in for a visit with your physician tomorrow. Or let's make a med change right now. And those types of things can happen in real time with remote patient monitoring, as opposed to, patient kind of blows it off, doesn't even know, and then, 2 months later they end up at the ER because they're in hypertensive crisis, or, they're in diabetic ketoacidosis. And so, that's really where you see a lot of the cost savings. And as I mentioned, there's a lot more research that needs to be done in this space to really demonstrate those cost savings and clinical protocols. As Dr. Chung mentioned, part of what we do as a company is we come into clinics and we help with those workflows for the physicians who are seeing a full slate of patients in person. We really help integrate this care model into primary care. And so coming up with good standards for people to do this, whether with a partner or in their own clinic, is really, really critical, so that we can actually make sure that we're generating that return on investment.
Yeah, for sure. You gave something that I'm going to turn to Sarah with a little bit. One of the pieces that Robert sort of wove into his narrative there was about the importance of that contact with the patient, and sort of the patient experience is another really important facet, I think, of remote monitoring. Can you sort of talk about what the diabetic community sees with, patient experience with these wearable health devices?
Sure. So we know that data is super valuable when it comes to a person and their care plan, but the way that doctors are getting that data isn't working. And Dr. Chung and Claudia spoke towards this a little earlier, but a person with T1D goes to their appointment with their endocrinologist. While sitting in the room, the doctor is going to download the data from their devices and looks at it. And while the reading component is really important, that mechanism of just sitting together while it is being analyzed isn't working. And doctors aren't getting paid to look at the data ahead of time. And, this is the system that we are left with. And it doesn't seem that this system has evolved to accommodate the factors of analyzing patient data.
Yeah, the analysis portion, I think, is really key, and we've seen some changes to that at the policy level that are going to slowly implement over the next couple of years, which unfortunately is a long time frame, but slow is better than no, in my opinion. So that's a key piece as we move through, trying to make sure that the data can be useful to people. So I want to turn to Dr. Chung and talk a little bit about one of the other pieces. You've talked a good bit about sort of the features involved in the Apple Watch, but I know that over-the-counter hearing aids has been a really big piece for you all lately. So I want to talk to you about how you feel like that might impact health equity, health access to hearing aid going forward.
Absolutely. So we are really excited to be announcing 2 new features for hearing. Just this year, they were just announced and released. But many people don't know that about an estimated 1.5 billion people live with hearing loss around the world. And unfortunately, 80% of people have not had their hearing tested in the last 5 years, What's even more shocking is that we have a large hearing study in collaboration with the WHO and University of Michigan. And in that study, we found that 75% of people diagnosed with hearing loss go untreated. That's significant because hearing loss can lead to social isolation, depression, and we know that it leads to early cognitive decline. That's why we are so excited that this year we've just launched new hearing features that are available right on AirPods, as you mentioned, Taylor. This includes a hearing test that was extensively validated against gold standard tests and a hearing aid that can be customized to a user's hearing needs based on either the hearing test that they took from the AirPods or an audiogram that is imported from a clinician's office. Now, it's our hope that by bringing these medical features to a device that's used every day by millions of people around the world, we can improve access to hearing aids. That's because the cost of AirPods is only a couple of $100 compared to most over-the-counter hearing aids, which often sell for over $1,000. And so not only are we making hearing aids more accessible, we believe we can reduce the stigma associated with hearing loss while also continuing to improve the experience and usability of wearing hearing aids.
Thank you. Dr. Chung, talking about that is really important, looking towards the future and the ways that we can improve remote monitoring, the ways that we can improve access and equity going forward. So I want to turn to you, Claudia, and, from your perspective, representing these doctors in Northern Virginia, sort of what are some of the hopes you have for the advancement of health access and health equity as we look towards the future?
Well, I would really love to see, policy and legislation move towards just providing devices for Medicaid and Medicare patients without having them to pay their 20% or the copayment. That would be ideal. To really empower physicians to be able to use the data and incorporate the data flow, the data capturing into every visit, so into their workflow. As Dr. Chung had alluded, and Apple can fund that solely, cheeky me. I would really love to see also like closing the gaps on the social drivers of health using technology. And it's easy as if you use an Apple phone, for instance, you can query for pantries or shelters or financial assistance, something like that, something of the sort. So that it just empowers the individual so to take some onus on and direction as to on their needs, and not solely rely on the system itself. I hope that answers your question.
Absolutely. I think, you pick up a really key point there, which is the idea of empowerment is sort of a thread that we've followed throughout this whole discussion as we talk about the things that remote monitoring can give to people, the things that wearable health devices and access to that data on your own health can give to people. So I'll go to you, Sarah, and talk a little bit more about some of the goals you have for policy work to improve health equity and access in this next Congress that starts very, very soon.
Sure. So there's something called the Special Diabetes Program, referred to as SDP, which provides funding to NIH for T1D medical research, like new therapies and accelerating progress to prevent, treat, and cure T1D. And it just so happens that the funding for the SDP is scheduled to expire at the end of this year. And there is really strong bipartisan support, and we are really hopeful that it will be renewed. Senators Collins, Shaheen, and 53 other senators sent a letter just last week to Senate leadership urging the renewal of the SDP. Also, Congresswoman DeGette and Congressman Bilirakis are currently circulating a letter in the House. And we really, really urge that if your member has not signed on, we really encourage them to do so. And the deadline to sign on is this Friday. So a lot of bipartisan support for the Special Diabetes Program, and we're really hopeful that it will be renewed at the end of the year.
Absolutely. A great program.
Mhm.
So we've been talking a little bit about some of the solutions for the challenges that we mentioned in the beginning of our discussion here. So I want to talk a little bit about, as Brian mentioned in his opener, the Wear It Act. That's the Wearable Equipment Adoption and Reinvestment in Technology Act. Don't ask me how long it took me to memorize that. So the bill is currently introduced in the House. It would clarify that wearable health devices are eligible for reimbursement through both FSA flexible spending accounts and HSA health savings accounts. So I want to, the goal here is to take some of this money that is already being withdrawn from people's paychecks, that is pre-tax, but that is not being spent currently. One study showed that in 2020, I think it was $4.2 billion were left in flexible FSAs at the end of the year that were unable to be spent by the people who had that money withheld from their paychecks. So, we want to make sure that people who have FSAs and HSAs can use that money that they have earned on devices that meet their needs. So I'll go around. I see, Robert, you've got your mute off, so I'll go to you first on sort of how do you think that a bill like the Wear It Act would be helpful to accessing remote monitoring and other interventions?
So, yes, I have a lot to say about this. That's why I went off mute. So first of all, the reimbursement from Medicare and other payers generally kind of is designed to cover a single device. And it does currently. So we often get into situations where we have to choose which one's more important. So we might send a blood pressure cuff to a patient or a blood glucometer to a patient. And really they need both. And so we don't like being in that situation. And I can tell you the clinicians who work for us really don't like being in that situation. They always ask me, well, can we just send 2 here? And I'm like, I would love to do that for every single patient, but we just can't do it with the margins that we're generating. So one, I think opening this up for patients to be able to go purchase their own devices, which many of our patients do choose to do. So we'll often recommend, well, if you want to lose weight, go get a scale, and we'll also incorporate that into our program. We just sent you a blood pressure cuff. And so that type of optionality for patients to be able to use this money that's already set aside for their health, I think is going to be really helpful for what I'll call sort of like clinical or formal RPM. I'm going to take my Avenue Health hat off and just be an American citizen now. I have an FSA. I did not use my entire FSA last year. I cannot even believe that it goes back to the company or it goes back to somebody else if I don't spend the money from my FSA. And I find that to be very troubling in and of itself, right? Now, the Wear It Act, I just want to make one final comment on it. This is a blood pressure cuff. You can buy this blood pressure cuff in CVS, Walgreens, Walmart, anywhere that you go, Amazon. It does blood pressure and heart rate. Every single blood pressure cuff I've ever seen does blood pressure and heart rate. That is a multifunction device. It's technically not allowed under FSA and HSA rules. For the sort of multifunction device prohibition. That's ridiculous. And I'm sure plenty of patients are going and buying these anyways because it's recommended for their treatment of their condition from their local store. And so like the technology has far outpaced the legislation in this case. So it really is time to change it and to open up this type of avenue for these dollars that are just sitting there and not being spent when it's the hard-earned money of American citizens. So I find that to be rather troubling. So
certainly, we are seeing very, very gradual changes at the IRS to cover some of these more multifunction devices, but they're doing it after a long time of review. They're doing it on a case-by-case basis. They're not really taking into account the way that a lot of technology works nowadays, where if you've got, as Robert said, if you've got a device that not just measures your blood pressure, but also takes your heart rate or has an EKG scanner or tells the time, those sorts of devices are generally not covered currently. So Dr. Chung, I see you've come off mute and I would love to hear your opinions on this topic.
Yeah, I just want to add to that. The other thing that I think is difficult right now is that many of the devices are kind of for that single function, which is you have your pedometer, you have your blood oxygen monitor, you have your life alert monitor to potentially alert you for falls. And they're really just meant for that medical function. And I think what's difficult then is that person has to constantly be carrying around multiple devices in order to benefit from their use when they need it. Whereas when you have many wearables like the Apple Watch, it's a device that you're actually not using per se for the health features. It is there to help you with communication. It's there to help time. It's there to really help you stay connected. And so the fact that there are so many health features on it means that you really get the benefit of having something that is with you all the time, that is then therefore maybe monitoring whether or not you have had an episode of AFib. And so we think the Wear Act really just provides additional avenues for patients to access wearable technology, which will help them really take control of their health.
Definitely. Sarah or Claudia, do you have thoughts on, how something like the Wear Act might affect the way that your communities use remote monitoring or wearable health?
Sure. I'll just add for the type 1 community, when you use a continuous glucose monitor in unison with an insulin pump, they work together through an algorithm to give you real-time control to manage your type 1 diabetes. And that is so important to the community, like eliminating the multiple finger sticks and injections per day when you have a device on your body. And it really just enhances the accessibility and affordability, like the Wear It Act, of these incredible life-changing devices, which is really just gonna improve health outcomes and quality of life, right? And so FSA and HSA, the money in those accounts can be used for these devices, also insulin, and they really help patients to cover costs where they might be paying out of pocket for, and really helping to manage diabetes and make it more affordable.
Excellent. Thank you. Claudia, do you have anything to add on this before we move on?
I think that we've covered it. We've covered everything just about. I mean, I don't know. I think that, if we are successful at passing this legislation, and, I think we will, that it just becomes another tool in the doctor's bag to treat patients and to make it easier for patients actually to access their physician. And I think we also need to sort of, on a broader scale, we need to look at those people who cannot afford devices. And so I think I'd like to see also address that at some point.
Certainly. I'm a big proponent of there are many avenues that we need to travel down to get to a better, more inclusive healthcare system. So, Robert, do you have something else to add on this piece before we move into some Q&A?
Yeah, just regarding the sort of tech-witty concept, which, if you're not familiar, it's sort of the referred to as the digital divide, or there's disparities in access to broadband internet connection, to cellular towers, to Wi-Fi, and so a lot of rural areas and a lot of sort of low-income folks may not have as much access to these types of care programs. So what we want to do is bring those folks into the fold more. We don't want to say, oh, well, these wearable technologies or these RPM programs are just not going to reach everybody, so we want to disincentivize them. I've heard that said before. We want to make sort of I'm going to quote Jose Andres here, we want to make our table longer. We want to build a longer table here. So we want to have programs that allow internet connectivity, which at this point I believe is really a social determinant of health. Being able to access physicians via telemedicine, which, by the way, is still not permanent at last I checked in the Medicare program. So that's a baseline thing that we definitely need as well. But these wearables are here to stay. I talk to medical device manufacturers all the time. They are adding Internet of Things connectivity, cellular technologies to their devices to allow this type of transmission. It makes a lot of sense There's a ton of research going on right now to improve care models for a whole bunch of conditions. We've talked a lot about diabetes and hypertension today, but we've also got a whole host of other conditions that people are working on. Stroke and COPD, congestive heart failure, chronic kidney disease. There's a lot of work going on in this space for conditions that cost the US health system a lot of money, that cost patients a lot of money. So we certainly do need to bridge that digital divide, and that is the solution here, to sort of allow this natural evolution of healthcare and sort of care models to continue to advance with technology. And then my last point, if I may, sorry to delay the Q&A here, but is it's not just rural access either. Folks that Claudia brought this up really well. Folks who are working multiple jobs, who can't get into a standard office visit from 9 to 5, they have to be at work. This is something where they can bring health into their daily life while they're at work. They can bring health at home. And so that access, when we think about it, is often like geographic disparities in access to care. It's not just geographic, it's time-based disparities. Like most medical offices, as I'm sure everybody knows, they're open from 9 to 5. And so we need to be able to bring chronic care models to people who may not be able to fit into that window.
I think that's a really great place to end it off. You know, we've really putting a bow on the importance of wearable health technology in improving health equity, in expanding access to healthcare for all kinds of people, whether they be people with chronic conditions, people who live in unserved or underserved communities. You know, having more options and more access, I think, is going to be key moving forward as we try to make a healthier America. So I want to really thank our panelists here. I'm going to move into one or two questions from our Q&A. And these, you know, I know we have not prepared ahead of time, so please feel free to jump in with your thoughts in our last couple of minutes here. So our first one is, how does a fee-for-service versus a value-based care model affect the strategy for wearable devices?
I have some
Hey,
thoughts. Dr. Chang, you're going.
You and I.
Let's have Claudia go and then Robert.
Well, I think I talked about value-based services and models, and I think that those are working fine within the physician community. The fee for service, I think, would open up more possibilities just because it would give the physician more honest and more agency over what the patient needs, or what the patient can maybe even purchase, or the direction the patient wants to take on that plan of care. But value-based contracting, you know, I don't think is going to go away. So I think we have to work with what we have for now.
I would say that the sort of the clinical model is roughly the same. So between the two of them, a lot of our customers are participating in the Medicare Shared Savings Program, for example. They're a part of an ACO. They still get paid fee for service, and so they see this as sort of a way to ultimately generate cost savings in sort of acute care avoidance, right? So they get paid fee for service for doing the remote patient monitoring, and then assuming you run a good remote patient monitoring program, you target your high-risk patients, and you avoid hospitalizations during the year, you generate additional shared savings for that clinic. And so it's a lot of times seen as an intervention to improve performance under value-based care contracts or value-based care arrangements. But it works really nicely under both. So if you're in a value-based care model that might be capitated as opposed to sort of a hybrid between fee-for-service and shared savings, like the MSSP model, the capitated payments certainly should incorporate the costs associated with running a remote patient monitoring program. Because at the end of the day, what we've learned from value-based payment over the last 12, 15 years is it's really easy to make payment changes. Like, you know, you still have to teach people how to do it, and you have to bring people along and organizations along. But the hard part is changing care models. And care models are, at the end of the day, what causes the clinical outcomes that you see from value-based care. And so we need to be thinking about not only value-based payment changes, we also need to be thinking about how those value-based payment changes can affect the care models that are being used that actually interact with patients every day.
Excellent. Okay, go ahead, Claudia.
I'm sorry, I may add just one thing to
No,
that is that, you know, this idea of having all these tools at the physician's disposal and putting so much responsibility on the delivery of care on the part of the physician, which is okay, but you know, there's a lot of non-compliant patients out there. And so I think that sometimes meeting the matrix, the target matrix for value-based contracting are pretty honest on the physician community.
Yeah. Well, we have reached our time here. I want to thank again our panelists. This is an excellent discussion. I think really going to kickstart our advocacy, continue our advocacy, all of us on remote monitoring, on wearable health, on health equity. So thanks again to our panel. Thank you to our audience for sticking with us for such an awesome discussion. And really hope you guys have a great rest of your day. Thanks all.
Thank you.
Thank you. Thanks for the invitation.